Thanks very much, Lou. Thanks for the organisers for inviting me again to speak. I learned a lot at this meeting, so thank you. I was, until recently, a member of ATAGI, but everything I talk about today, no state secrets, it'll all be public domain. Of course, it was a very quiet period on ATAGI the last few years with, no controversies, no real issues, but I'm going to talk a little bit about pneumococcal disease and then the vaccines we have now and in the future. Pneumococcal disease encompasses a range of infections. In fact, streptococcus pneumoniae can be carried asymptomatically, but it can cause non-invasive disease, and it can cause invasive disease such as bacteremia and meningitis, and pneumonia can be invasive or non-invasive. Make no apologies in presenting this slide again. It's a real seminal paper, and I think it's important just to think about historically. This is from 1964, but it actually has data from the early 20th century, really, which looks at the natural history of this condition. So people who were admitted to Boston Hospital in the early 20th century had about a 15% chance of surviving the first 3 weeks. Penicillin was a real game changer, and after penicillin treatment, over 85% of people survived bacteremic pneumococcal pneumonia. The middle bar, just for interest, was actually convalescent plasma, which is quite effective for pneumococcal disease, possibly not so effective for COVID-19 as it was used recently. But I just want you to have a look at the outcomes at day 5, and really there's no difference in the groups who had penicillin and who didn't. And you could say, well, that's 1964, before modern intensive care, etc. But this is a paper from this millennium, and even now, about 2/3 of patients with pneumococcal bacteremia died within the first 3 days of their illness. So instead of relying on antibiotics, we should try and probably prevent this severe illness. So pneumococcal vaccines. The vaccine that we've had for decades has been the pneumococcal polysaccharide vaccine. The currently available vaccine contains 23 of the most virulent common pneumococcal capsular polysaccharide types. This is a Cochrane review. It's a few years old now, but there's probably not many new randomized controlled trials using this vaccine, but it does show that there's a significant reduction in invasive pneumococcal disease using the polysaccharide vaccine. But if you're looking a little bit more carefully, if you just look at the studies performed in low-income countries, there's certainly a significant reduction in invasive pneumococcal disease. But if you look at high-income countries and people with chronic illness, the effects of the vaccine are not as convincing. And there was another Cochrane review which was looking at preventing pneumonia in patients with chronic obstructive pulmonary disease, and it does look quite effective. And I think this is quite a nice. This is the number needed to treat for benefit in preventing asthma, in preventing pneumonia, is about 19, which seems reasonably good. But there are issues with the vaccine, and this review looks at a lot of data if people are interested. And the protection from the vaccine may be lower in older adults, in people with underlying conditions such as pulmonary disease, and the effect of the vaccine is not all that long-lasting. One very recent paper I did when I was preparing found was this one. This is on vaccine safety. And it's quite an extraordinary study of almost 2 million. I think Alan was talking about the use of electronic medical records here, but this is a database study of almost 2 million people in South Korea using a self-controlled analysis. And bottom line is that there were no serious cardiovascular, neurological, or immunological events associated with the use of polysaccharide vaccine. So as we know, this is a very safe vaccine. The pneumococcal conjugate vaccines are also very safe in terms of serious adverse events, but I'm not going to talk any more about safety, even though I'm very interested in it. So the pneumococcal conjugate vaccines were developed. The first one had 7 serotypes, and since then we've had the introduction of PCV10 and then PCV13. So the conjugate vaccines use the polysaccharide capsule, but that's conjugated to a carrier protein. And the advantages and the most common carrier protein that's been used is a detoxified diphtheria toxin, and it has a T-cell dependent mechanism and stimulates the production of memory B cells, which is important for providing activity in neonates and also for longevity of the response. I think we'll hear a little bit more about PCV13 in children shortly, but in terms of adults, the key trial was the Capita trial from the Netherlands, now published about 8 years ago. It's quite an extraordinary effort, which I don't think will be repeated again. More than 40,000 people in each arm receiving either placebo or PCV13. And they had very intensive follow-up to if there was suspected pneumonia or suspected invasive pneumococcal disease, including the use of serotype-specific urinary antigens, which is available for this project. And the results demonstrated, and I should say this is in adults over 65 in the community in the Netherlands who had not had routine adult pneumococcal vaccination. So the results showed that the conjugate vaccine was effective in reducing vaccine type community-acquired pneumonia and also in non-invasive pneumonia and also in invasive pneumococcal disease, but pretty small numbers. So in fact, the event rate is a pretty healthy population, I think. The event rate was exceedingly low, even though it was certainly statistically significant effect. The good news is as expected, the immunogenicity lasted, and at 2 years there was, good persistence of immune response. Subsequently, we're not going to get more of those studies of 80,000 people with pneumonia. These are retrospective database studies looking at all-cause pneumonia, and I think some of them have different methodology and different patient inclusions, but there's been a consistent outcome of a beneficial effect up to 10% reduction of all-cause pneumonia in people who've had the vaccine versus people who haven't. So probably a lot of our data comes from the US, and not to step on the next speaker's toes, but this is old data that really when the first conjugate vaccines were introduced in children, there was really a dramatic effect in reduction of vaccine type invasive pneumococcal disease. And then with the introduction of the 13-valent conjugate vaccine, there was a further reduction of those extra 6 types causing invasive disease. But you can see in the green bar, there's still ongoing, as you'd expect, still ongoing invasive pneumococcal disease due to serotypes not contained in the vaccine. Now, in adults, and remember, the vaccine was just given to infants, it still had quite a significant effect in adults after the introduction of both the 7-valent and then the 13-valent vaccine. But you can see there, the green line, still quite a lot of disease due to serotypes not contained in the vaccine. And this is just a timeline of the recommendations in the US introducing the vaccines. And you can see that PCV13 was actually introduced before there was much data in adults for high-risk adults. Then after the results of the Capita trial were known, it was introduced for adults. And then a few years later, after an evaluation of the data and whether it made much effect on top of infant vaccination, they sort of changed the recommendation such that it was recommended to have shared clinical decision-making with your medical advisor about whether you should have the vaccine or you could just have the polysaccharide vaccine, which is, I think, a little bit of a confusing recommendation. But the field continues to progress, and there's now the availability of a 15-valent version of the vaccine and a 20-valent version of the vaccine, both licensed in the US in 2021. And over the next couple of years, the ACIP then had further recommendations recommending PCV20 for people who hadn't been vaccinated previously, and then more recently adding a recommendation for vaccination in addition to PCV13 in particular in high-risk individuals. So what about here in Australia? And I think I've spoken previously at this meeting about the tortuous pathway that led us to eventually recommending adult conjugate pneumococcal vaccination age 70 in 2020. So the current state of affairs is recommendation at age 70 to receive only the pneumococcal conjugate vaccine. Indigenous Australians are recommended to receive the vaccine earlier in addition to the polysaccharide vaccine, and at-risk people of all ages, or I think above 12 months, are recommended to receive both vaccines. And this really took a lot of work over probably a decade or more to get these vaccines on the National Immunisation Program. But there's more, and I think there has been a more streamlined approach to registration and approval of vaccines. And the 15 and 20-valent vaccines have both been approved by the TGA in 2022. And then last year, both vaccines were recommended by the PBAC for use in high-risk children to be added to the NIP. There's a little asterisk there of both of them, though. And the asterisk is this, that the listing was based on, among other matters, its assessment that the cost effectiveness of PCV15 would be acceptable if it were cost minimised against the comparator, which was PCV13. And the same wording applies to the 20-valent vaccine. So I think we need the previous speaker to look at the cost effectiveness of that. So what about future developments? Again, we still have, this is US data, but about 40% of the invasive pneumococcal disease cases are caused by non-vaccine serotypes. And that's actually serotypes that aren't in the 20-valent or the 23-valent polysaccharide vaccine. So there's still a lot of disease which we can prevent. And, you know, the question is, can we reduce the burden further with expanded serotype vaccines? Well, ask the question, and there are more coming. Merck have a 21-valent, that's one more than the competitor, vaccine that has completed early phase 1-2 trials and is in phase 3. And there's a couple of other newer 24-valent vaccines. And I'll just talk about those two briefly because they're a little bit novel. So this one is a 24 serotype vaccine, like I mentioned, but it uses this MAPS, or multiple antigen presenting system platform, and it has a fusion protein of two highly conserved Streptococcus pneumoniae proteins. And the idea there is that might provide a more broad protection against many different serotypes. Again, phase 1-2 completed with good efficacy and safety. And the other one has a different protein carrier. This is an enhanced carrier protein, and which is designed to have exposure of critical T cell epitopes and low ratio of protein carrier to polysaccharide, which have theoretical benefits. So we've got, I think in the grey, the currently available vaccines. We have the 15-valent and the 20-valent vaccines, which have been now registered. approved, recommended based on cost minimisation, plus a whole range of new vaccines, which is, very exciting. And there are actually a number of other novel vaccine targets that have actually already had early clinical development also. So there's a lot of interest in the field. So there's a lot of question marks for policymakers as to how we implement these. And there are a lot of challenges actually, and one of them is it's actually not that easy to infer the impact based on just our bacterial surveillance data. And I won't go into the details, but if anyone's interested, they can have a look at this paper. And probably even more important is how do we actually evaluate these new vaccines? So we've had good clinical data for the early conjugate vaccines, PCV7 and in children, and then PCV13 in adults more. But each subsequent study is based on comparing the immunogenicity of the new vaccine versus the old vaccine and looking for non-inferiority. But you can be non-inferior to one vaccine to the next, but by the time you get down to the third or fourth vaccine that you've compared non-inferiority to, you can have, and you actually do have, lower immunogenicity. And so that's a real challenge, I think, for evaluation of these vaccines. And actually, even how we do these evaluations is not clear-cut as well. So I think there's a lot of promise with the new vaccines, but a lot of other question marks as to how we actually evaluate those. So I thank everyone for their attention. Actually, I'm very pleased, Lou, at this forum, there's a lot of more experts in the room who I can ask the questions to.
So are there any Alan?
Tony, I'm certainly not an expert on pneumococcal disease, but I remember that years ago there were some thoughts of using an antigen such as pneumolysin as a more pan-specific antigen. Has there been any further work? Your slide went past.
Yeah, I think I went pretty quickly over that slide. I think that is one of amongst other many more, I suppose, potentially broad targets that have been looked at and look quite promising. Yeah.
Or maybe using it either in combination with the conjugate vaccine or using it as the antigen for actual conjugation.
Yeah, I think that's right. I think it's more theoretical, trying to find a more, it's a bit like influenza, Alan, looking at for the elusive universal flu vaccine with broad effects rather than trying to have type-specific vaccines. Yeah.
Tony, there's a question. It's got two parts. Is it the case that more serotypes is better for the conjugated vaccines?
Well, I mean, I think that's just a matter of coverage, I suppose. So the more is better in providing a wider range of coverage, and it's still overall at the moment, it seems that even with this amount of 20 or maybe up to 24 serotypes, we're still getting pretty good immunogenicity data for each individual serotype, although there's a couple of, and I think Sanjay might be talking about a couple of the challenges. I'm just giving a preview for the next talk.
So are we heading for PCV 50 plus?
Yeah, I think it may be, I think there might be some technological challenges with that many serotypes, and maybe Alan's comment about trying to find a more broadly target, a more broad target for pneumococcus might be a better way of doing it. Yeah.
So the second part of the question was, should it be age targeted? And Sanjay might have a comment on this as well. But
yeah, well, I think he'll talk about children. I mean, in adults, again, the age 70 was, I think, there for cost effectiveness, and the biggest burden of disease is in our older individuals. I know there was a concern moving from, I think it was a 65-year age group for polysaccharide vaccine to 70 with conjugate vaccine. But as I get older, I can see that 65 isn't particularly old anymore. So I think that's a reasonable approach.